If you see, if you can read what's written up over there, he actually had done a mathematical study as a medical student of how to, make psychological assessments. And this was going to be used in psychiatry. He had a mathematical mind, and he was an excellent illustrator, and this is iconic. Anybody who even opens a textbook of urology, leave alone pathology, will see this iconic thing there. So what was it about the Gleason classification? Why was it accepted when at that time there were very important, very people with uropathologists with huge egos and huge careers? And chief amongst them was Dr. Mostofi. Okay, so why wasn't it that Mostofi's classification, which he was pushing with great vigor to be used, what was it about Gleason's classification that became a hit? Well, I'll tell you, it was that he was a quiet man, whereas Mostofi and Gaeta and the guys at the Mayo Clinic were pushing their classifications. Gleason got up at this conference, which was being held at the behest of who? Not at the behest of pathologists. It was held at the behest of Willett Whitmore. And if anybody has heard of Willett Whitmore, you will know, or if you knew him, he was a lion, absolute lion. When Whitmore never squeaked, he roared. And when he roared, he said, you guys use all kinds of classifications, and we are trying to get something organized. We have to have a classification that everybody in America will use so that we can make sense of research and whatever other clinical research that we want to do. So it was Willett Whitmore who got all this together, and there were workshops that were held from time to time. Of course, the pathologists attended the workshops, but the final workshop had Whitmore. And whereas Mostofi was bombastic, and so was Gaeta, and to some extent Gerald Murphy, who wrote this paper along with Willett Whitmore, Gleason made his presentation and went and sat in a corner. Now, how do I know all this? I wasn't there, okay? I'm not that old. I heard it from one of the others who was there, somebody who was at Memorial Hospital and was invited along with, he was a pathologist, and was invited to that. And Gleason sat there very quietly, and Whitmore just finally, being frustrated by all of this, just got up and said, that classification, and he pointed to Dr. Gleason. Okay, so it's the classification that Willett Whitmore actually chose, and then everything was shut. You couldn't say anything anymore. And they, when they wrote the paper, they said that it was recommended that Gleason's classification was used because it was definable, it was simple, it was reproducible, and had compelling clinical relevance. So that is how the story of how Gleason came to be. But Gleason hasn't remained the same, okay? It has evolved like everything else evolves over the years. There was a 1, 2, 3, 4, 5 grades. Nobody even recognizes a grade 1 today. There may be some people who recognize a grade 2 in a TURP, but certainly on needle biopsies, nobody recognizes grade 1 and 2. It's more or less, obsolete. Those grades are more or less obsolete. But yes, there is 3, 4, and 5. These are the grades. And you have the primary and the secondary grades. And the definition of 3, 4, and 5 have changed over the years. And I just show you all of this. What was once upon a time 3, some of it is now 4. And somebody was talking about the Will Rogers phenomenon this morning. And yes, it applies to Gleason or any other system in which you start to rearrange grades, and then, you cannot use what you have been using before to decide whether something some treatment is good or bad, because you have changed the goalposts. Anyway, so this is how it all went, and now we have the issue, okay? And this was a paper that was published by no less person from the same Jonathan Epstein, etc. group. Is 3+3 actually a cancer? Because the way that we are now defining 3+3, that's Gleason 6, is this really a cancer? Should it actually be treated as a cancer? And this may, engender a gasp. Good heavens. And yes, I think it should engender a gasp, because 3+3 has been treated as a cancer, and countless radical prostatectomies have been done on this, on the basis of 3+3. Only now, people are looking back and wondering whether this is really a cancer. And I will just say this, okay? This is something that was said by Julian Huxley at a lecture, in 1950. Julian Huxley was known as Darwin's bulldog, because he used to defend Darwin's theory of evolution. And he said something that is, I think, very true. He said cancer must be defined in terms of what the tumor cells do, not what they look like. Otherwise, there's no meaning to what we say. So is 3+3 actually doing something that needs to be considered to be a cancer? And I think that there are pros and cons, okay? People say, yes, we should 3+3 qualify for treatment? Well, the reasons are on the right-hand side. Should not qualify for treatment are on the left-hand side. Now, why do people feel that you should not treat 3+3? And some of them is that you're over-treating a whole lot of people, because extremely few people with 3+3 cancers actually, and it's less than 3%, actually die of prostate cancer. I mean, this is data, okay? A lot of people might treat 3+3 because of the monetary benefits of actually treating rather than following up patients. It doesn't matter in this country, but it does, where you are actually being paid for doing something for the patient. And of course, when you look at the NIH consensus conference on what is low-risk disease, this Gleason 6 is top of the list, and of course you have the PSA of less than 10, and of course the T stage of this disease. But on the other hand, there are those who say, no, I think it should be treated, and you have to say that it is a cancer because it does invade tissues. Now the question is, lots of things invade, but does that actually qualify as a cancer? Well, that's a philosophical question, and we can sit here till the cows come home, and I can explain a lot of things that invade, but we don't treat them as cancers, okay? Biopsy Gleason score, they say, underestimates what you will actually find in a radical prostatectomy. Agreed. That is a reason to worry about what else is in the prostate, particularly as we know now that prostatic cancer may be multifocal. Some people say that you're missing an opportunity for cure by not treating this patient. Of course, there's always the question of medical liability. And a lot of patients, if they're told that they have a cancer, are fearful about what that means for them. So should we call it a cancer? Should we not call it a cancer? I think the jury is out as of now. 3+3 is accepted as a cancer. Now, whether you treat it or not is another question, and I think that's beyond my remit, except that something has now happened, because 3+3 is 6, and everything, you could go right from 2 to 10. People felt that, I've got a 3+3, so I'm sitting in the middle of this whole spectrum. Now, they've changed this, and there's grade grouping, and 3+3 is called grade group 1, and patients understand that it isn't as bad as grade group 3 or 4 or 5 or whatever. And I think it makes counseling that much easier. Now you see that figure on the right, and now that we've been watching the Ukraine war and all that sort of thing, it looks like some kind of bombing strategy, To me, it at least looks like that. Well, prostate cancer, because we're doing needle core biopsies, it's a very complicated thing because the whole core may not be involved, a part of the core may be involved, some part of the core might have a 3+3, another part of the 3, another part of the core might have 4, and so on and so forth. So how should all this be reported in a way that it actually makes sense to the clinician? And I don't want to ask here or take a poll as to whether clinicians actually can make sense of a lot of pathology reports on core biopsies, okay? Anyway, this is what Gleason was all about. But I must say that, I find uropathologists very democratic. Have you seen this now? And this is ISUP. And you know how they make decisions in ISUP? Well, they pose a question, okay, or they take a heading and they pose a whole lot of questions, and then they take a poll. And they take a poll, and if anything is 70% or above, then that is taken as consensus, and that appears in their next classification or in their deliberations. So look at it. I mean, I have never found any other pathology group that is as democratic as the uropathologists, okay? And I do read the literature, and I don't see this kind of thing that is happening everywhere. They're so democratic, let me tell you, that there are even Maharashtra, style splits. Look, GUPS split from ISUP in 2018. And then both published grading systems in 2019. And they don't agree. So now you tell me, do we have to look at GUPS or should we look at ISUP? I tell you, thank God I'm not a uro-oncopathologist, okay? I understand, but it's difficult, I guess, to choose where you are. So if you're a GUPS guy, then you may have GUPS. If you're an ISUP guy, then you have this. And just as a joke, I'll ask a poll question over here, okay? Why did GUPS split from ISUP? Is it because the top dog decided he couldn't get his way and walked out with his coterie? Is it that ISUP, which was essentially an American, sort of based organization, did it become too loaded with European skeptics? Was it a leadership issue? If I can't be the captain, then I will take my stumps and bat and ball, and you can all suck your thumbs. Well, or all of the above. Now, let me tell you, I know the answer, but I am not going to highlight it over here, okay? So you can take your pick, and I'm sure all of you will probably, okay, you said it, not I. All right, so now let me finish with prostate. Let's go to the bladder. And here is, I've put there WHO 2004, which was what ISUP said in 1998. And most of you are surgeons, okay? And tell me, can you see the difference between the top and the bottom things? No, they look more or less the same, and you're right, okay? Except that the top is a flat lesion, which we call dysplasia and carcinoma in situ in the bladder. The bottom are papillary lesions, which are also not invasive. You know that carcinoma in situ is not invasive, right? Yeah, that is also not invasive. But the uropathologists will call non-invasive carcinomas, non-invasive lesions, carcinomas. Now that, to me, is, I don't know where it comes from. It's a sigh that I can say. So people thought, let's have some histological grading, what is this pun lump and this and that. Let's look at it again. So there were reappraisals. And now, instead of 3 grades, it became 4 grades. But Non-invasive carcinomas still remain. Nobody looked at that part of the thing. And they still do today, because there you are. That's the WHO 2022 classifications. And I think, this is the perversity of uropathologists who insist on having non-invasive carcinomas. Okay? To you guys as uro-oncologists, you just take it for granted. But I'm talking from the point of view of a generalist pathology. And I can't understand non-invasive carcinomas, okay? The minimum thing that a carcinoma has to do is to invade, right? But it's non-invasive. So, how about a schema from a generalist, okay? Why can't you call these things single, if you have a single papillary lesion, you call it a papilloma, with and without dysplasia. If it's multiple, which it often is in the bladder, call it papillomatosis with and without dysplasia. If it's invasive, then you obviously call it an invasive papillary carcinoma, and the flat lesions we have already dealt with. Now that is something that I, as a generalist, would be very happy to accept. But then, I'm well past my sell-by date, and nobody's going to listen to me, okay? So more's the pity. But I'm just telling you that that is the problem with uropathologists. A completely different mindset. Gleason started the whole story, and now, of course, we have the non-invasive cancers in the urothelium. Okay, let's come to the kidney now, and I don't want to say too much because a lot has been said by Santosh about the kidney. Life, once upon a time, was very simple, and you can see there. There was carcinoma, there was renal cell carcinoma, there was an adenoma, which is more or less, disappeared from the scene. There was carcinoma, renal cell carcinoma, and others. And you can see who was there. F.K. Mostofi, the guy who lost out to Gleason. Yes, absolutely. Then, of course, over the years now,